Hi, my name is Tiffany Williams. I'm going to be going over your introduction to cardiac electrophysiology, which is one of my favorite subjects. So I'm excited to be here today with you. Let's start by a review of the anatomy of the heart. So we have blood coming in through our superior and inferior vena cava. It's going to come into the right atrium. It's going to move down into the right ventricle through that tricuspid valve. Then it's going to move up through the pulmonic valve, through those pulmonary arteries into the lungs. When it gets to the lungs, it exchanges gases, and then it comes back into that left atrium through the mitral valve, down into the left ventricle being that big muscular chamber, and it's going to have that big pump through that aorta so that the blood can get back out to the body and perfuse our cells, tissues, and organs. That heart itself has to have its own blood supply. The muscles and structures of the heart actually have to get their own oxygen and their own type of nutrients to be able to produce those muscle contractions so that we can get blood where it needs to go throughout the body. So we need to keep the heart itself alive, the actual pump. So there are coronary arteries that supply that blood. You have the right coronary artery that runs on that right side. So we're talking about that in terms of anatomical position, so on that right side. And then you have the left main coronary artery that comes down and branches into the left anterior descending, and then the left circumflex that kind of wraps around to the back. And then there's going to be the posterior descending artery that's going to be on that back side. So these can actually become blocked or occluded. We hear so often talking about heart attacks or MIs in terms of paramedic care and treatment. So we can actually see on an EKG machine if these are blocked with some changes that we're looking for. Well, as you can see, as we look at the heart here, there's vessels that surround the 360-degree structure of the heart. So we have to have different views and looks to be able to look at all of that as we try to diagnose this patient with their corresponding ischemia or infarct or injury patterns that we might see on the EKG, which could be representative of an occlusion in one of these coronary arteries. So let's talk about electrophysiology itself. We have electrical versus mechanical impulses of the heart. An electrical impulse tells that heart to beat. So if the myocardial cells respond appropriately, a mechanical response generates muscle contraction, blood movement, and hopefully a palpable pulse. So just because we have electrical conduction through the heart does not mean that we're actually producing a pulse. We think about this often, if you've heard of it, called pulseless electrical activity. Well, that's exactly what's happening. The heart is sending electrical impulse, but those heart muscles aren't responding appropriately to create that contraction and that blood movement that we need to be able to keep our tissues and structures alive. So the heart has automaticity, meaning it can generate an electrical impulse independently of outside stimulation. So it can beat regardless of what the nervous system is doing at that time. Now, the nervous system can come in and adjust it up or down, but it can beat on its own, which is a pretty cool feature that it has. Cardiac cell anatomy. There are going to be two types of cells in the heart. We have our nodal or our pacemaker cells. Those are 1% of the entire cardiac heart itself, and they are the ones that generate the action potentials. They drive those contractile cells to actually send that impulse and actually do the contraction. So they're in charge essentially. And then those contractile cells are the muscle cells, or those cells that produce that contraction. Hopefully they can still receive electrical impulse without contraction, but hopefully when they get that electrical impulse, they do stimulate that contraction. And they, of course, are able to undergo that rapid depolarization, which is driven by those autoarrhythmic cells, which are also known as nodal or pacemaker cells. So the conduction through the cell is dependent on those pacemaker or nodal cells to be able to go down and the organized system, the organized fashion, the roadways that go through that heart, so we can stimulate contraction appropriately and through the right channels. How does this happen? Well, down into a cellular level, we have our nodal and contractile cells. This one right here is going to be representing our contractile cell, if we're talking about it in terms of resting membrane potential. So if you look on the bottom, it does say that cardiac myocytes have a resting membrane potential of approximately negative 90 millivolts. So if we're looking at this cardiac cell, we see it's at a negative membrane potential of negative 90 millivolts. That's going to be its resting membrane potential, because typically the inside of the cell is more negative than the outside of the cell. And that's that membrane potential, which is the electric voltage difference between the inside and outside of the cell. Well, that's based on the movement of those ions, specifically sodium and potassium, that as they start to exchange, they can change that membrane potential either positive or negative, so that we can hit a threshold and then we can send out an impulse through the heart in terms of an electrical conduction through the heart. So as three sodium exchange, 2 potassiums are going to exchange with it, so the 3 to 2, so that we get a change in that electrical potential, which can stimulate an action potential. We'll talk about that here in a moment. Knowing that and also mentioning here that our nodal cells are going to be at a resting membrane potential that fluctuates, but it is going to be around that negative 60 millivolts. So the nodal cells, negative 60 millivolt for resting membrane potential, and then our cardiac myocytes, the contractile cells, negative 90 millivolts. So let's talk about the pacemaker cell, or the nodal cell's action potential, so how it begins. So you see up there, the SA node and the AV node are going to be our pacemaker cells. So hopefully the SA node is stimulating our initial response. We want the SA node to be the one that's ultimately in charge, that sends that initial impulse. Well, how does this begin? Well, it begins by that exchange of the sodium and potassium. So as you can see, we talked about the nodal cells having that resting membrane potential around that negative 60 millivolts, right? So as that sodium starts to come in, it hits a threshold potential, and that stimulates those calcium channels to open. Calcium rushes in, and we get that electrical conduction that stimulates the next cell, the next cell, the next cell, the next cell. And then as hopefully creates that contraction. And then as our potassium starts to move out, we go back down to resting membrane potential, which is known as the repolarization. So sodium moves in, calcium moves in, we have depolarization, and then we have repolarization as that potassium moves out of the cell, going back to that resting membrane potential so that we can receive another impulse at this time. Now, if you look here at the end of this here with the sympathetic and parasympathetic response that are going to come in. So if you can see that if you get sympathetic stimulation, you're actually going to receive this impulse a little bit sooner there. We see on this x-axis that this is representative of time. So if that sympathetic system comes in, it's going to actually increase the speed of contraction. Or if the parasympathetic system comes in, it's actually going to decrease that speed, and that action potential is going to happen a little bit less. So showing what happens normal and what happens if they're with regular automaticity, but then also showing if that sympathetic nervous system kicks in or if that parasympathetic nervous system kicks in here. Now, if we're looking at the contractile cell action potential, it's going to be a little bit different. This is going to be very, very, very much based on our sodium. So our nodal cells have a lot of calcium involvement, and our contractile cells have a lot of sodium dependency here. So when we have that negative 90, right, negative 90 resting membrane potential, we are going to have some sodium that starts to exchange. We're then going to hit a threshold potential, where we're actually going to stimulate more sodium channels to open, and we're going to create this big sodium influx into the cell. So sodium influxes into the cell, and then we come up, and as we get to the top around that positive 30 membrane potential, We're going to shut off that sodium. Potassium is going to move out as we come back down. And then we're going to start to exchange calcium and potassium, which is going to create a little bit of a negative plateau there, but it's going to have a little bit of an even out property with calcium moving in, potassium moving out, and then eventually that potassium or that calcium will shut off here, and then we move back into that repolarization. So we have depolarization and then into repolarization that's going to move down. Now, these are the cells that are going to be creating that contraction, hopefully. So they can still create that electrical impulse, but they're also hopefully going to be creating that contraction. And as you can see, those are going to be your contractile cells, your muscle cells. So all the heart tissue in there that's going to be hopefully having this contraction as they spread out this electrical impulse from cell to cell to cell. Now, so let's go back to those words we were hearing. We were hearing depolarization and repolarization. So depolarization is the wave of electrical flow through the heart that happens when the potassium and sodium trade places. So remember, this doesn't mean that the heart is actually contracted. And repolarization is when the cell charges are returning to their original position. Once they're completely repolarized, the heart is in a, quote, ready state for that next electrical impulse, right? We know that the heart doesn't beat once and stop, so we need it to keep beating, keep beating, keep beating, and be able to receive that next impulse. So all of these stages and things that need to be happening from depolarization to repolarization are very important to receive that next impulse properly. Let's start with the order of operations as that electrical conduction moves through the heart. So it hopefully starts out at that sinoatrial node. That's what would be considered normal, right? So that sinoatrial node sits up at the junction of the superior vena cava and the right atrium, right? So up here at the top. It's that yellow glowing area up here. It's a spindle-shaped structure, and it's the primary pacemaker of the heart. It drives that spontaneous depolarization. And it occurs at a faster rate than the other cardiac cells, which makes it the one that's in charge and the one that typically sends out these impulses. It has a rate of automaticity, so its intrinsic rate between 60 and 100 beats per minute, which should sound familiar to you. Most of us, healthy individuals, are going to have a heart rate between 60 and 100, and that's because our sinoatrial node is most likely the thing sending out our electrical signals. So it should fall in that 60 to 100 range. Next is going to be our AV node. So that impulse is going to travel from the SA node through the atrium, cell to cell to cell, into that AV node. So the atrial ventricular node. So it's a bundle found near the septum at the base of that right atrium. So this is the base of the atrium, and that's where the AV node is going to be. So this is actually where the speed, the conduction is delayed in this AV node, and it's designed that way. It's designed to have a delay here so that the ventricles can fill up with blood. If the conduction moves too quickly through the AV node, the ventricles will not have enough time to fill with blood to be able to pump enough blood out to the body. So we want the conduction to slow down through the AV node, allow the ventricles to fill, and then the conduction can spread out through the ventricles, creating that contraction, sending the blood out. So if the atrioventricular node is actually the one creating that initial impulse, it's going to fall at an intrinsic rate between 40 and 60. Well, we know that is falling falling lower than what our normal conduction would be. So this would be a backup mechanism. We don't want it to be between 40 and 60, but if our SA node fails or the atrium decides to not take over, we're going to be sitting at that 40 to 60 range with our AV node sending out the conduction. So paying attention to rate is very important when we're actually naming or diagnosing rhythms. Next, we've done the SA node through the atrium down into the AV node. We've paused to allow those ventricles to fill with blood, and now we're going to start to move through the ventricles. We have to get the ventricles to contract to send that blood out. So we're going to depolarize the bundle of His. That's going to be just below the AV node here, sending the bundle of His down. So it's a tract from the AV node to the interventricular septum. So it's going to spread that potential through the ventricles. The bundle of His is going to divide in to the bundle branches, and those are going to be right here. And then it's going to spread down. It's going to spread down through the bundle branches down into the Purkinje fibers and then out into the cells and hopefully create that ventricular contraction. Now, if the ventricles from the bundle of His all the way down throughout the ventricles have to take over conduction, their intrinsic rate is going to be 20 to 40 beats per minute. That's pretty slow. That's concerning, which is why we don't want to hear words like ventricular conduction or ventricular tachycardia or an idioventricular rhythm. We don't want the ventricles producing our initial response and our initial contraction, because they'll do it at a slower rate and it won't be as efficient. So that can be problematic for our patients. So after the bundle branches, this is just showing what we talked about. We send down an impulse from our SA node down to the bundle of His through our bundle branches. We're going to depolarize the interventricular septum first. Then we're going to do major depolarization down here of the ventricles, and then we're going to spread up this way. So it's going to move down in this direction, just like this, and spread through. So it's going to go from here down, then starting to depolarize this area, and then it's going to spread out into these two areas. So this interventricular septum, major ventricular depolarization, and then basilar depolarization. So it's like a roadway system, and that's how it's supposed to send that signal so that it can contract properly. So we have the SA node through the atrium, down to the AV node, pause, bundle of His, bundle branches, down through the ventricles, out the Purkinje fibers, and we hopefully have that ventricular contraction and blood flow through the aorta down to the tissues, cells, and organs. Let's talk about our nervous system innervation. So we're going to have an autonomic nervous system interaction that can have some degree of control over the electrophysiology of the heart. The parasympathetic system tends to be dominant over the sympathetic nervous system, but your vagal stimulation that could be coming in over and going over here to the AV node can come into play and actually slow that conduction down, or your sympathetic system can come in and actually speed it up. So the brain sends a signal to the heart and says, hey, and sends acetylcholine and says, we need to slow this down. And then your sympathetic system, your epi and your norepi, and sends a signal over telling the heart, hey, we need to speed it up here. Maybe you have a disease process, or you're running and you need to get more oxygen. Those would be instances where you would want to have something speed up the heart. Now, the parasympathetic response is going to be the vagus nerve. That's your cranial nerve 10, right? That's going to supply the atria, the SA node and the AV node. So the SA node stimulation results in that enhanced potassium permeability with reduced frequency of those action potentials. And at the AV node, that enhanced potassium permeability results in an increased AV nodal delay, so slows it down even more than it does naturally. Okay, so that shortens that plateau phase that we talked about on that action potential, right? Shortens that plateau phase, and it reduces that atrial contraction. Your sympathetic nervous system is going to be fibers that supply that SA node and AV node and the ventricles. So SA node increases that rate of depolarization and increases the frequency of action potentials. And at that AV node, it's reduced to AV nodal delay, so it speeds it up through there. The conduction pathway is going to be a fast spread of those action potentials, and it increases the strength of those contraction and quicker relaxation, speeding things up, right? Fight or flight. Now, let's talk about the EKG itself, the electrocardiogram, right? An electrocardiogram, ECG, if we're talking about C cardio, or EKG, which comes from their German terminology of the K for cardio, is recording the heart's electrical activity, right? A 12-lead ECG records from 10 electrodes, but offers 12 views. So you have 10 stickers, 10 wires, but you're going to have 12 different views. Remember how I talked about all those coronary arteries being around the heart? Well, we need to have a view of all of them. We need to have a view of all the sides of the heart to say, hey, there might be some ischemia or oxygen starvation on the backside of the heart. Well, I have to be able to have some sort of view to be able to look at that. Or what about the bottom of the heart or the side of the heart? So I need to have views that go all the way around the patient's chest so I can get that entire view of everything that's going on. It's like having a surveillance camera at your house. If you only have a camera on your front door, you're only going to be able to see intruders that come through your front door. But what if somebody goes over the side, over the fence, or in the back door? We want to make sure we get a view of everything that's going on there. Now, electrical versus mechanical function. So how do we assess the mechanical function of the heart? So with the mechanical function of the heart, we're actually going to be feeling the patient's pulse, right? And then how do we assess the electrical function? We're going to be looking at the cardiac monitor. So we can assess mechanical function with the pulse, blood pressure, and the electrical function. We actually put that on the EKG machine. So when assessing both mechanical and the electrical function, we want a blood pressure cuff, we want to feel the pulse, and we want to put them on the cardiac monitor because that's going to show us all the functioning from mechanical and electrical and making sure that that's actually producing a pulse. Because if it's not producing a pulse, it's not getting blood flow, and that's what's important. We need blood. We need blood to our tissues, organs, and cells. We need to get, and the blood is going to carry oxygen and glucose and important things that we need to have throughout our body. So let's talk about leads versus electrodes. So our electrodes are those adhesive stickers that you place on a patient. And it's also the wires that get attached to them. So if you have 10 stickers on a 12 lead, you're going to have 10 wires that get attached to it. Now that's not the same as talking about leads. You have 10 electrodes, 10 wires, but you're going to have 12 leads or 12 views. Okay, so you're going to have 12 leads, 12 views. And if we're talking about a 4 lead, that's those limb leads that you put on. So you're going to put on 1, 2, 3, 4, right arm, right leg, left leg. And that's actually going to be your 4 electrodes, 4 wires, and you can actually get 6 views from that. You can get lead 1, lead 2, lead 3, and then lead AVF, AVR, and AVL, which is pretty cool, just from those 4 leads. From those 4 wires or stickers. Now let's talk about the Einthoven triangle. So this is what we were talking about here. You've got your right arm, right leg, left leg of those electrodes or wires. So we have 4 electrodes and wires, but we can actually get those 6 views from here. Okay, so 4 electrodes and wires, but we can get 6 views just from these 4 stickers. Now, if you put this on a patient, assuming that this is how we put them on the patient in this picture on the right of this individual, this is as close to the heart as we want to get up here on the top. If we're talking about these electrodes here, we want limb leads to go on the limbs. So we want them typically on forearms if we're talking about the arms, but if we need to move them closer to the body, at least try to get them around that deltoid area. Try not to move them onto the chest. It's just not how they were designed, and they need to be at a certain distance from the heart to get that correct reading. So try to put those limb leads out on the arms where they're designed to be put, and then the leg leads down on the legs. Now, your right arm, and left leg are going to be your actual views. Your right leg, your green lead, is going to be your ground. So it's just trying to give that grounding effect and try to eliminate some artifact. So we're actually using the right arm, left leg, and left arm to create this Einthoven triangle, which you can see based on where it's mapping it out. So you have your right arm lead over here, you have your left arm lead over here, and then you have your left leg lead over here, creating that triangle. Now, if we're talking about lead 1, which is in the first picture here, this is going to be lead 1. Okay, you're looking from this side. Okay, the positive electrode. You're always going to be looking from that positive electrode, and you're going to be looking in this direction. Okay, so that's basically imagine it like a camera. You put a camera on this positive view here, that positive view, that positive lead is going to be a camera, and you're looking towards that negative lead. So you have the positive lead looking towards the negative, okay? And it's looking in that direction. So we can see anything moving in that plane, coming away or towards that lead. Now, this one should look familiar to you if we're talking about lead 2 here. This is the one we typically look at whenever you're looking at an EKG book, and you just see one QRS generation across one looking QRS complex or EKG reading. It's typically going to be your lead 2. This is because this is how your normal electrical conduction happens from a right, down, and left angle. So it's going to start over here in the heart and move down in this direction. Well, if you look, the lead 2 is here and it's looking up this way. And that's basically looking exactly at the electrical conduction that's normal in the heart. So basically looking right down the barrel of the conduction coming down, best view in the house kind of thing. So that's the lead we want to look at most often, because it should have a good look at the electrical conduction moving through the heart. So you've got your positive lead here looking towards your negative pole up here, which makes it, if you look over here, bipolar. So these are going to be your bipolar leads, your leads 1, 2, and 3. And that makes sense by looking, we have a positive lead looking towards a negative lead. So that's bipolar. Now let's look at our last bipolar lead, which is going to be our lead 3. So our lead 3 is going to be looking from down here. Remember, that's our positive. We're always looking from our positive up towards our negative. So we're going to be looking in this direction. So imagining that our camera is down here, right? We're looking up towards that negative lead. And we're going to look up, we're going to look up that way. So the negative electrode, our bipolar electrode, we're going to look up that direction from that positive. So those are going to be our positive, negative, bipolar leads. Okay, leads 1, 2, and lead 3. Now, with these four stickers, these 4 electrodes that you put on this patient, remember how we talked about there's 6 leads or 6 views? Well, what happens here is that all these leads here create a negative terminal in the center of the heart. So in the very center of this patient's heart, it creates a negative terminal. It has a computerized calculation that creates a negative terminal or a negative electrode in the center of the heart. So when you're looking at these leads on the bottom here, AVF, AVL, and AVR, we're talking about augmented leads. So that's why they're pointing basically to the center of the heart here, because that's where their negative pole is actually at. So it's going to create that negative pole using all three of those electrodes to create that negative pole. So when you're looking at AVF, you're actually looking from AVF, augmented vector foot. So you're looking from the foot up, straight up. And if you know anything about cardiology yet, you know that AVF is an inferior view. So not a bad view, but looking from the bottom. So it's an inferior lead, meaning it's looking straight up at the bottom of the heart. So augmented vector foot is looking from this positive to this negative here upwards. Now your AVL is going to be augmented vector left. So that's going to be on the patient's left over here. Okay, so that's your positive, and then it's looking to the negative here, and so it's going to look in this direction. Okay, so augmented vector left, looking towards the center of the heart. Now the same as, it's just going to be the opposite for AVR. So you're on the right using this positive, looking towards the center of the heart, so you're going to be looking in this way. So if we take all of those together, okay, and I draw this patient's heart here, and I take lead, we're going to be having lead 2 is going to look up this way, right? Lead 3 is going to look up this way. lead 1 is going to look this way. Lead AVF is going to look up that way. Lead AVR is going to look down that way. Okay, and AVL is going to look down that way. We get quite a bit of different views of what's going on here. And this is actually going to create the hexaxial system that you can see here. So just like I drew on that other page, you can see how this hexaxial system is formed. So you have AVL looking this way, AVR looking this way, you have AVF looking that way. You have lead 2 looking up this way, you have lead 1 looking that way, and you have lead 3 looking that way. All of these looking on a vertical plane, so up and down, okay? So together those limb leads and the augmented views form this hexaxial system, okay? This can also help you determine the patient's axis. What axis means is that normally the heart conducts from the SA node down to the AV node, and then through the heart, and the general direction of electrical conductions happens at about this angle right here, okay? So about that angle. So this and this pink part right here is representing what a normal axis would be. The patient's electrical conduction happening somewhere in that general direction. We want it moving that way, right? We know that if an electrical conduction is generated in the ventricles, we talked about it earlier a little bit, if it creates that from the ventricles, which would start down here, we know it's going to send that conduction, it's going to have to send that conduction cell to cell to cell this way, which is going to be problematic. And it's going to be not going on its correct axis. It's actually going to have an axis over here in this blue area, which is not good. Now, again, just to reiterate, let's look at those cameras. So pretend each lead is actually a camera. It's pointing at a site. We talked about it, how lead 2 is looking up this way, right? Lead 3 is looking up this way. Lead 1 is looking over this way. It's lateral view, okay? Your AVL is looking in, your AVR is looking in, and your AVF is looking in, right? So this is going to help us get multiple views of the heart. And this is important because, like we talked about with surveillance camera, it's kind of the same thinking about Craigslist, right? You probably wouldn't buy something on Craigslist without getting pictures from all those angles. For the picture that you have here of the toaster, you're probably going to say, oh my gosh, you know, I asked for more pictures and this one's on fire, so there's no way I'm going to buy this unless they charge me less money, right? Because everybody wants a good toaster from Craigslist. Let's talk about the EKG paper. So this is what the EKG paper is going to look at. You're going to have big boxes and then little boxes that fill up those. But this is just a general view of what that EKG paper is going to look like. One of the things you want to look at when you have your EKG printout is you want to look at the paper speed. Now, every monitor you're probably going to work with in the field is most likely a 25 millimeter per second speed, meaning that's the speed the paper is actually moving through the machine to produce a reading or a graphical representation of that electrical conduction as it moves through the heart. So if a different paper speed is used, and the most common one is slowing it down to 50 millimeters per second, that will have to adjust the calculations. But it's highly unlikely that any monitor you use in the field would not be this 25 millimeters per second. But you can know that based on, it should have a reading somewhere here at the bottom that tells you your paper speed. And we'll talk about it in the course as we go. Something to pay attention to here is the different paper speeds. So as you can see, each complex is representing electrical conduction. Now, I don't have a patient in front of me, so I don't know if this electrical conduction is actually creating a pulse, but assuming it is, this is actually representing my patient's pulse. So beat, 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 right? Now, if I slow the paper speed down, okay, it doesn't change exactly what's going on, but it just spreads it out on the paper. It just spreads it out. So meaning if I'm using this EKG paper as a way to calculate my rate, I can't trust it the same. We typically use the box calculation method, or we use a 6-second strip method. Well, that's going to change if you're using the 50 millimeters per second. But luckily for us, most of the ones we're using are this 25 millimeters per second. So all the calculations I'm teaching you are going to be based on that 25 millimeters per second, which is the monitors we'll be working with. Now, how is that? What is on that graphical representation? What does it mean? Well, voltage, okay, so voltage is that amount of force, or the amount of movement of those electrical currents that's going through that heart. So it's force, and it's going to be measured by the height. So if I have lots of cells in one area, I'm going to get a bigger voltage, because each of those are going to be creating their own amount of voltage as they start to move. Well, the more cells I start to add onto it, the more that voltage is going to be measured, because what it's doing is, on this x-axis, this is going to be time, okay? And then this is going to be our voltage measured in millivolts, okay? So as time goes by, the more force I have, the bigger voltage I'm going to have. And then whether it happens slower or whether it happens faster is going to be based on how up and down that line actually is. And we're looking at the time here. So it's measured this will be representative of that one of those big boxes, and then the little boxes that are going to be on there. So you're actually going to have 5 little boxes inside the one big box. So each little box is 0.04 seconds, or 40 milliseconds. And then all of your big boxes are going to be 0.20 seconds, or 200 milliseconds. This is just another picture of that, putting it in that pink graph paper that we're used to seeing, right? So we've got these representing 0.04 seconds, or 40 milliseconds. And then again, the big box of the 5 little boxes is going to be your 0.20 seconds, or your 200 milliseconds. Then when we're measuring up, we're doing the voltage, right? So one of the big boxes is going to be 5 millimeters, which is equivalent to 0.5 millivolts. So we have to have 2 big boxes to equal 1 millivolt. Now, this is important to keep in mind in terms of measuring this. When we do this y-axis here, when we're measuring that voltage, this is going to be used very commonly when we're talking about ST elevation. And we actually measure it in millimeters, not millivolts. You've heard of 1 millimeter of ST elevation in 2 contiguous leads. Well, that's what we're talking about. So each one of these little boxes, if one big box is 5 millimeters, we know each of these little boxes is going to be 1 millimeter. Okay, so 1 millimeter, or 0.1 millivolts, but we typically talk about it in millimeters when we're talking about ST elevation, and we'll learn that when we get to the 12 lead. So something else to pay attention to when you first get your EKG paper out is examining the EKG calibration. Just as we talked about, this is 2 big boxes, right, or 10 little boxes, which is equal to 1 millivolt. One big box is equal to 0.5 millivolts. Two big boxes is equal to 1 millivolt, or 10 millimeters. Okay, so that's just showing us, and you're going to see something just like this here that looks kind of like a top hat. It's actually going to look just like that on your EKG machine, and it's going to show you what your calibration is. You can adjust this calibration if you're trying to basically like zoom in to look at something, and you're more than welcome to do that if you're trying to zoom in and try and look at something. Once you actually print the EKG though, and you print a 12 lead, it's going to default back into its original calibration, and that's because it has to use that as a calculation. So just know once you print it, it's going to come out with your correct calibration and default back to this calibration. All right, so we've got a talk about what is inside this EKG machine. We talked about that there's a graphical representation and we have EKG paper. Well, how does that actually come out of the machine and get to us, and what is it actually representing down to that cellular level? Well, it's actually used on a galvanometer, which is over here. Okay, so basically this is the technology that is used inside this machine. Okay, a good way to think about it though is think about your Apple Watch, right? A lot of us have Apple Watches. If you're able to actually get a reading on your Apple Watch and see an EKG reading across the Apple Watch, which is pretty cool. There's something though that you have to do very specifically when you're trying to do this. You can't just look at your watch and say, oh, what does my EKG show? You actually have to take your opposite hand, depending on which arm you're actually wearing the watch on. So if I'm wearing my watch on my left hand, I take my right hand and I actually put my hand on this little toggle here. So what I'm actually doing is I'm actually creating a circuit. So I'm creating a positive pole and I'm creating a negative pole. Remember how we talked about the bipolar leads? Well, what this is actually creating is this is actually creating in the body, right? This is actually creating a view this way. And if we think about it, if this is positive over here and negative over here, and I'm looking this way, because I put my hands and I created this circuit right here, it's actually a lead one view. I'm looking at a lead one view on this watch, which is really, really cool. So what this galvanometer does right here on this left side is it does the same thing, but it takes this negative pole and it takes this positive pole, and then you have the patient's heart in between, and it creates, you see here, you've got a positive and you've got a negative, and it does the exact same thing. Well, we do that with this EKG monitor, but we do it 12 different times with 10 different leads. Pretty cool stuff. Before we get into a couple more things, let's talk about and remind ourselves of depolarization and repolarization. So depolarization, the wave of electrical flow through the heart that happens when the potassium and sodium trade places. So the potassium sodium trades places, that resting membrane potential, if we're talking about our nodal cells, it's -60. If we're talking about our contractile cells, it's -90. So in terms of talking about contraction, -90 is our resting membrane potential. When those potassium and sodium ions trade places, we hit a threshold potential and we become more positive. That positive impulse moves through the heart from cell to cell to cell to cell, creating that electrical flow. And that is graphically represented on our EKG. Okay, so remember though, just because we see it on the EKG doesn't mean it's actually performing a contraction or a pulse. And then once all those cells have become positive, we've moved from a negative resting membrane potential positively, we have to get back to that resting negative membrane potential so we can receive another impulse. So we have to repolarize. And that's when the cell charges are returning to their original position. So we start kicking out that potassium, sending it back out to become more negative inside that cell, so that our heart is in that ready state for that next electrical impulse, so that we can get another heartbeat and another heartbeat and another heartbeat. Okay, I want you to think about this. I put this picture on here, go Broncos. I'm from Colorado. So I put this picture on here thinking about it like a stadium. Okay, everyone knows that when you're in a stadium, sometimes they'll do the wave, right? Think about the cardiac electrical impulse just like that. You have somebody that starts the wave, the SA node, hopefully, right? You get that really excited fan and says, we're going to do the wave. And so they're the SA node, they send the impulse out, and then everybody follows along, sends the impulse, sends the impulse, sends the impulse, and it goes around, okay? So depolarization, the sodium potassium exchanges, it becomes more positive. We send out a positive depolarization all the way around the stadium. And then everybody has to put their hands back down. And then the heart, this is the last cell to be depolarized. It's going to be the first to repolarize. So we just send that back the other way, but it's going to be going back to that negative that negative resting membrane potential, which means it's going to be that if you're imagining the hands going back down, but now they're in a negative movement throughout the stadium. Depolarization, positive movement, repolarization, negative movement, thinking about it like a wave. And the more stadium, the bigger the stadium, the more fans, the more cells in the heart, essentially, the more voltage you're going to get. So the bigger the deflection. And you know this because you, even now, before we've gone over everything, if you think about the QRS complex, right? You've got the QRS complex that comes out. We know that this is the biggest part of the electrical conduction. Well, what part of the heart is that? The left ventricle, because it's big, it's muscular, it has to pump blood out to the heart, so it has more cells. More cells equal more force, which means you're going to get a bigger voltage, right? Which is that Y-axis. Very cool. Now, another way to explain this is to think about this like batteries. Each of these D batteries right here is going to be 1.5 volts, okay? 1.5 volts. We know that the heart measures in millivolts, but we're going to talk about it in 1.5 volts. So imagine that each of these batteries is a cell, okay? Is a cell in the heart. So if I take this voltmeter right here, essentially like our galvanometer, our EKG machine, I'm going to put a positive and a negative pole, okay? I'm going to put the positive and the negative pole on there, and I'm going to take these wires, and I'm actually going to attach them, okay? And we're going to measure the voltage in there, okay? We've created a current, and we're going to measure the voltage. I'm going to get 1.5 volts moving through this current, okay? So it's going to be 1.5 volts moving through of force moving through this battery. Now, if I have these two batteries together and I put this I create a circuit on it, what's it going to do? Well, it's going to add these two together. So now I'm going to have 3 volts of force in that circuit. So the amount of energy in that circuit is what I'm going to be able to measure. So think about it the same way in the heart. If something is happening at the same time and there's more cells, it's going to be a bigger voltage or a bigger force. Think about those cells like batteries. We're going to add that together. So I'm going to draw a couple things here to try to explain what I'm talking about. So if I draw a galvanometer here, okay? So I'm going to draw a galvanometer. It's going to have a positive pole. So this is going to be positive, and it's going to have a negative, right? So that I can create that here. So if I have my galvanometer machine, positive 30, positive 20, positive 10, I'm going to have negative 10, negative 20, this is negative 20, and negative 30. Okay, so this is my galvanometer machine, right? This is what's inside the EKG machine, essentially how that works. So what I'm going to do is I'm going to make this a positive. I'm going to make this a positive electrode, okay? Positive sticker, positive electrode, okay? And then I'm going to take this negative end. I know I'm kind of crossing them here, but it's because I want to actually create lead 2 here. So I'm going to take this negative pole, okay? And I'm going to put a negative up here. So what I'm creating right here is I'm actually creating a lead 2. So I have my positive lead looking up that way. So imagine this positive is my camera. I'm looking up towards that negative lead. Okay. So if I was to have the heart here and I just took a chunk of cells out, I cut this chunk of cells, okay, and I put it over here. I'm going to have this chunk of cells. So taking that piece of heart, and I'm going to take those cells. So thinking about it like we talked about with the stadium and the wave, the batteries, we're going to think about it in terms of the heart now. Okay, but we're not going to look at it quite the big picture left yet. We're going to look at it in terms of just the little piece of cells so that we can understand this. So let's imagine these are our contractile cells, okay? So they're the ones at the -90 resting membrane potential, okay? So that means that they're resting, which means they're all negative right now. So these are all negative cells. We're all negative, okay? So we need an impulse to tell us to send an electrical conduction and to hopefully depolarize, right? So let's say an impulse comes in, positive impulse comes in and says, hey, you need to depolarize. We're going to hope it's the SA node, but that comes in, sends that signal in. And so each cell is going to start, like the wave in the stadium, becoming more positive. It's going to be positive, 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 and it's going to start to send that positive signal down. And it's going to go cell to cell to cell, just like the wave. And it travels through, if I take two of those cells, it travels through what are called gap junctions. They basically travel through these gap junctions to travel through. And the speed that they move is based on these gap junctions, not the amount of the force or voltage, but the amount of gap junctions. And that's going to come into play here in just a little bit when we're going to talk about that. So this positive impulse is going to move in this direction, okay? We're moving in this direction, cell to cell, and we're becoming more positive. So all of these added together are going to create a vector, okay? So this vector is created. I've now created this vector. When I send that impulse, I'm going to create positive impulses moving in this direction towards a positive lead, okay? So if I send that impulse towards a positive lead, I am going to get a positive deflection, okay? So I'm going to get a positive deflection, okay? So if I read that on my EKG machine, it's going to just, as the paper moves across, it's going to have a deflection that goes upward, and it's just going to have an ink on it, and it's just going to make a mark, okay, as that starts to move through. So then as we start to go into the ventricles where there's more cells, let's talk about what would happen, okay? So say I add another layer of cells on here. Well, now we talked about it. If I add another layer of cells on there, I still get positive moving towards a positive, but it's going to be much bigger now. So I have to make this vector much bigger. So what is my galvanometer going to do? Well, it's going to go because I have a positive impulse moving towards a positive lead, I'm going to get an even bigger positive deflection. Okay, so it's just going to read a bigger positive deflection because there's more cells in there. Okay, now we talked about it again. We talked about it earlier in talking about speed of conduction. Speed of conduction is based on those gap junctions. The amount of cells is going to be representative of that, of the voltage, okay? So if this arrow on this galvanometer is going through a part of the heart that has really like a lot of gap junctions, those positive impulses are going really fast. What it's going to do is just going to send this arrow up really fast. So it's going to create a wave like this, up and down really fast. Whereas if I have a area of the heart with not as many gap junctions in there and it happens kind of slow, it's going to just lift up the arrow and have something be kind of nice and slow like that. Yeah. So something to keep in mind is that's going to be speed based on the amount of gap junctions and what part of the heart you're in, and then your amount of voltage is going to be based on the amount of cells that you have in the area. How big of an area is it? Okay, now we have to think about this. I'm going to get a little eraser here real quick, so we can talk about some of this. Let's erase this. Okay. All right. So we'll draw our galvanometer again. Okay, so you've got positive 10, we'll do this positive 10, positive 20, positive 30, negative 10, negative 20, negative 30. And we have our negative pole and our positive pole. Okay, so let's take our positive pole. We want to create a lead 2 view, right? So we're going to put this on essentially our left leg here, and we're going to take our negative lead, we're going to put it on our right arm. Okay, so we've got the negative here. We've created our bipolar lead, right? Which is lead 2 looking in that direction. Okay, so what we want to think about is we're going to talk about now repolarization. Okay, so we're going to say that this chunk of cells that we depolarized, and we know that depolarized means that we made it more positive. Okay, so we made it more positive. We now need to become more negative again. Okay, so we need to repolarize. So everything is positive, okay, but it's not moving right now. Remember, we have to have movement of this electrical conduction for it to be measured graphically on the screen. If nothing's happening, this arrow will just stay flat and we will get an isoelectric line or a flat line on this, okay? It has to actually be moving. It doesn't matter what the charge is, those charges have to be moving, okay? So now that we need to have repolarization, we're going to have the outside of the heart, the last cell to be depolarized is going to be the first to repolarize. So these cells right here, the last ones are going to start to become more negative. So we're going to become more negative, and we're moving in this direction. Okay, so we have our negative vector moving away from a positive lead. Okay, so this is where it becomes a little bit tricky because we're calculating a mathematical calculation of potential differences between this positive and this negative. So as it starts to become more negative, a negative moving away from a positive, we're actually going to get a positive deflection. Okay, and this is we'll talk about it in a minute, but we know that repolarization on our EKGs is represented by a T wave that normally looks like that. Well, that's a positive deflection, right? So that's representing repolarization. It's negative. Negative moving away from a positive is going to be a positive deflection. Okay, so that's something to keep in mind when you're looking at these and understanding if you're looking at repolarization or depolarization. A negative moving away from a positive lead is going to have a positive deflection on that galvanometer or the EKG machine. Now let's talk about, since we brought that up, what I do want to talk about is what if that depolarization or positive impulse is moving away from the positive lead. Okay, so let's talk about that. Okay, we'll just try to erase that right there. Okay, so we've got this. Okay, so this is going to be positive 10. All right, so we're going to take our positive here. We're going to make our lead 2. We're looking up this way, and we're taking our negative, and we're creating that bipolar, the bipolar lead of lead 2. And lead 2 is looking up this way. So what we're going to do is we're going to take our chunk of cells again, okay, the chunk of cells. And now let's talk about what we're going to see if this impulse is actually moving away from this positive lead. So we know if nothing's moving, we're going to have the arrow is not going to be moving at all, okay? The arrow won't be moving. So all of these cells, we're talking about resting membrane potential, okay? So we're going to be in that negative 90 if we're talking about contractile cells. So let's say we receive an impulse, okay? We receive an impulse, but it's on this other side. So it's going to be coming in this way, okay? So something told these cells to depolarize, which means all of these are going to become positive, and this cell is going to move through the gap junctions there and do this cell, this cell, this cell, this cell. So we've got a positive vector moving away from a positive lead. So we have a positive vector moving away from a positive lead, okay? This is going to create our negative deflection, okay? And the speed of this is going to be based on if there's a lot of gap junctions. That'll come clear in a minute. But it's going to be the speed is going to be based on those gap junctions, and the amount of force or the voltage we'll get would be based on how many cells. So if I add more cells here, then I'm going to get a bigger negative deflection, okay, on that EKG machine, which is going to be represented if it's fast, it's going to be down. If it's slow, it's going to look like that, but it's going to be negative, right? Because it's a negative, or it's a positive moving away from a positive, and it's going to have a negative deflection, okay, as the paper moves across this way and this arrow moves either up or the arrow moves down at 25 millimeters per second, which is normal for that, okay? So let's talk about this in regards to the heart, okay? We have 3 speeds of conduction when it comes to the heart. We have slow conducting cells, we have moderate speed conducting cells, and we have fast. And we've already talked about it. You're ready for this. You know that if you have, the more gap junctions you have, the faster the depolarization or the repolarization. Well, the depolarization is going to be, repolarization is always going to happen at a slow speed. But depolarization, as it moves through those gap junctions, is going to happen at different speeds. And the more gap junctions, faster. Less gap junctions, slower. There are 3 speeds of conduction in the heart. So your slow conducting cells are going to be your AV and your SA node. Your moderate conducting speeds are going to be all of your contractile cells, all the ones that aren't in his Purkinje system. So your his Purkinje system are going to be your fast conducting cells, okay? So we can even do this in terms of color. So let's have our slow conducting cells be red. So we'll say our SA node is over here, and our AV node just drawing it here. Okay, so we have SA and AV. All right, so those are going to happen slow. But once they fire, they're going to send it out to the contractile cells, and it's going to move across the heart. Now, if we represent that might be too light. Let's do orange for this one. Okay, so if we want, the contractile cells are going to be represented as our orange. So that's going to be all the contractile cells in this atrium. So let's talk about how it's going to go through here. So our contractile cells are moderate speed. So if our AV node fires, we're going to have to send that impulse through the atrium, which is moderate conducting speed, meaning there are just moderate amounts of gap junctions through there. So if I send this impulse, I'm going to, from the SA node, I'm going to become more positive as I start to move down towards that AV node. And I'm going to spread out that impulse like that wave in a stadium down to that AV node. So the first thing I'm going to see on an EKG machine is I'm going to see atrial depolarization, positive impulses moving down towards the AV node. Okay, so if we're going to talk about it, let's talk about it in terms of lead 2. So we're going to put the positive lead here. We're going to put the negative pull, so the negative electrode here, but we have our positive electrode here, which creates our positive lead, and we're going to look up this way. Okay, so we're going to look up that way. So now, if we're depolarizing the atrium, okay? And we're moderate speed moving towards, right? If we add this vector together, it's going to be moving about in that general direction towards that positive electrode. So we're at moderate speed towards a positive electrode, and the atrium isn't a very big part of the heart. It's pretty small. So we're going to get that galvanometer is going to create that positive moderate speed deflection. That's going to be our P wave. Okay, so that's going to be represented by our P wave. Now we're going to move back towards our slow conduction. So we know we've now made it to the AV node. Okay, we know we have to pause here. So normally on an EKG, we get what's an isoelectric line. This is going to be our PR segment. And if we include the P wave, it's going to be our PR interval. So PR segment without the P wave and PR interval if we include the P wave. This is going to be representing AV node depolarization, or the pause at the AV node, so that we can get blood to fill in the ventricles and give it time to do that. So we want it to pause here. Now, why would this measure a flat line if something's actually happening and moving? I thought you said that if something's moving, it's going to be measuring. Well, if I was to draw the AV node out here, it's going to be made up of all these teeny tiny little cells. Because of all these teeny tiny little cells, teeny tiny little gap junctions, the machine just can't pick up the very, very small, right? Remember we talked about voltage being in terms of size. It can't really pick up the reading on there. So it's actually going to just read it as kind of this flat area. Now, this actually comes into play very important when we're talking about ST elevation, because we use certain isoelectric lines as reference point to be able to measure our ST elevation. We shouldn't use our PR interval or our PR segment to measure as a baseline for our ST elevation, because electrical, quote, stuff is happening. The AV node is actually depolarizing. There's actually something happening. So we don't want to use that as our line. We want to use something that is actually truly electrical silent and not moving any electrical conduction. So that's when we're sitting at our resting membrane potential, which is going to be our T to P segment. That means the end of repolarization of one impulse to the beginning of the SA node depolarization of the next, where something is truly not happening. That's what we want to use as our baseline. So we don't use this PR interval. So again, the PR interval is representative of that AV node depolarization, that pause there so we can fill up the ventricles. So the next thing that is going to happen here is we've now moved into our FAST or our His-Purkinje system. So that actually spreads down like this. We've got our left bundle, and we've got our right bundle, okay? And then the Purkinje fibers that come out, right? So this is our fast conducting cells, lots of gap junctions. So they look something like long with lots and lots and lots of gap junctions at them. So they move impulses super fast, super fast, okay? So the first thing that is going to happen here is that impulse is going to start to come down, and it's actually going to move down this left bundle first. It's going to move down this left bundle, and it's going to spread out this interventricular fascicle, and it's going to start depolarizing in this direction. Okay, it's going to depolarize all these contractile cells of the septum in this direction. Because of that, it's actually going to create that vector. And this isn't a very big area of the heart. The interventricular septum isn't a super big area of the heart, but it's going to be depolarization, which is positive. And if I make this arrow, it's going to be moving in this direction. Okay, so a positive, which is moving away from a positive a positive lead. And we talked about it. We have a positive moving away from a positive is going to be a negative deflection. But this is a small area of the heart, but it's moving fast. So we're going to get small, negative, but fast. Small, negative, but fast. So we're going to get our Q wave. Okay. Next, we're going to measure that depolarization coming out all through here. Well, what's going to happen is, remember, our EKG machine is actually going to measure the biggest impulse, the biggest amount of force happening at one point in time. So what it's going to do is, because the left ventricle is bigger, that vector is going to be measured in more of an arrow moving kind of in this general direction. So we've got this positive deflection, this positive vector moving towards a positive lead, and this is a big area of the heart. So we have big, positive, and fast. Big, positive, and fast. So we've got our R wave now, which is major ventricular depolarization. Okay, so the last of the ventricle areas to be depolarized are these areas. That's the basilar areas, okay? Which means we have to move up in this direction and this direction. Well, in looking at those, they're not very big, and it's going to average those vectors together. So what it's going to do is it's going to create, I'll draw a vector in a different color just because I have a lot of green down there, but it's going to have a vector on the small area of the heart, okay? Because that basilar area is pretty small, but it's going to be positive, small, positive, and it's away from a positive lead, away from a positive lead. So small, negative, fast, away from that positive lead. Negative, fast, and moving away from that positive electrode, okay, in a small area of the heart. Excellent. So now what's happening is in the heart is we're actually going to get an isoelectric line here. So we're going to get an isoelectric line. What that means is, even though everything is now positive in the ventricles, nothing's moving. Remember, it's measuring movement. So nothing's actually moving right now, which means it's going to have this isoelectric line. So if this is our, sorry, I forgot to write that, this is our S wave. Okay, so now guess what we have? QRS. This whole complex is our QRS complex. It's going to have our septal, major ventricular, and our basilar depolarization. So all of the ventricle, right? And then now that it's depolarized, it's going to sit at a depolarized state until it repolarizes. Okay, so you might be asking, well, this is repolarized. When did the atrium repolarize? Well, the atrium repolarized during the ventricular depolarization. Remember, we talked about this. The EKG machine is actually going to read the biggest vector, the biggest amount of force. And if the atrial repolarization is happening at the same time the ventricular depolarization is happening, it's going to measure the ventricular depolarization, that bigger force. So the atrial repolarization gets lost in that QRS complex. You probably will not see it unless it happens a little bit early or late. And you see it outside the QRS complex, but most of the time it'll be lost in that QRS complex. Okay, so now that this ventricle is sitting in a depolarized positive state, we need to get back to resting membrane potential. So we need for all of these cells to become from positive back to negative. Remember, with that big squeeze and things not able to move, it's going to be those outside cells that are going to repolarize first, those outside cells. So we're getting the outside to in becoming more negative. So we're actually going to be moving in this general direction, negative, becoming more negative, away from that positive lead. Remember, we talked about this. We get a negative deflection, repolarization, moving away from a positive lead. We're actually going to get that positive deflection here. So that positive T wave which is representative of that ventricular repolarization. Okay, so that's going to be our atrial depolarization, P wave. AV node depolarization is going to be that PR segment. If you add the P wave, it's going to be the PR interval. Then you're going to get that deflection, negative deflection here of that septal depolarization. Major ventricular depolarization is the R wave. Basilar depolarization is that S wave. And then we're going to pause during depolarization, and we're going to repolarize with a positive T wave in that lead 2 view, which is right here, right? Okay. So that's how it's going to look like for that repolarization. Okay. I was going to draw that over here for you. So if I left this one open, so I want to make sure we'll use that. So that's going to be that negative moving from this outside cell, moving in this general direction, negative away from a positive lead. Okay. Perfect. Let's talk about the waves and those segments that we were drawing on that complex. So we have different waves, intervals, and segments. So we have an isoelectric line. That's the line created on the EKG paper when no electrical current is flowing. That's a net zero. Now that doesn't mean that there's not actually charges. It just means that nothing's moving. It can't see any movement, so it's not going to measure anything. Waves are going to be the deflections above or below that isoelectric line. Whether they're sharp or curved, we talked about it, is based on that speed, the amount of gap junctions that are there. If it's fast conducting, like in that his Purkinje system, it's going to be up and down really fast. And if it's more curved, that's going to be more slow, less gap junctions, more of that general contractile cells throughout the heart. Now, an interval is an area between and possibly includes the wave itself. So if we look over here at this complex, we see that the PR interval includes the P wave right there. And you might be saying, well, I get that, but why is it's actually stopping right before the Q wave? Well, you won't always see Q waves. You'll start to learn this as we go a little bit further, but you won't always see Q waves because remember, it's based on camera views. Not all those leads or camera views can pick up all the movements. So you may not see a Q wave. So it's basing the fact on that you might only have an R wave. But if you do have a Q wave, you measure the PR interval from the beginning of the P wave to beginning of that Q wave, that negative deflection there. Okay. So that's going to be your PR interval. A segment is a straight line or area of electrical inactivity between waves. Remember how we talked about if we don't include the wave here, that's going to be the PR segment. Okay, so right here, PR segment, ST segment. Now the ST segment is important to keep in mind because when you have we're talking about ST segment, we're actually talking about that ST elevation. The ST segment is either up or down based on if somebody might be having ischemia or injury. So that ST segment is going to be very important. Our PR interval is another really important one that we're going to use. And we do calculate QT interval for some stuff as well, and the QRS complex. But those measured together. So that's the difference between the isoelectric line, wave, intervals, and segments. Let's go over that again in these pictures just to make sure that we have an understanding of it. So during one heartbeat, SA node generates an impulse. We depolarize the atria. We depolarize the AV node, but our EKG can't pick it up because the cells are too small, just not seeing enough movement moving through those teeny tiny little cells with little gap junctions. Then we get depolarization of the bundle of His, which is your fast conducting cells, lots of gap junctions. And then you get your interventricular septal depolarization, then major ventricular depolarization, then basilar depolarization, which is the entire ventricular depolarization. And then we're going to repolarize. So let's look at our waves again. SA node depolarization starts with the electrical impulse through the atria. Okay, so the SA node depolarizes and it's going to stimulate that impulse through the atria. So we won't actually see the SA node itself firing, but we will see how it stimulates the atrial depolarization. And that means we want to see that P wave upright moving in that direction towards a positive lead, which is why we want to see it upright and at moderate speed, right? Because this is one of our moderate speed conducting cells, those contractile cells. So that SA node sends the impulse. We go through the atria. You can see that yellow, that sending that impulse through that atria, depolarizing cell to cell to cell, creating that P wave, that positive impulse moving in this direction, right? Towards, if we're talking about lead 2, towards that positive lead, we get that positive deflection. Now we've gone to the AV node. We want it to pause here. Little cells, little bit of cells, little tiny gap junctions. We're not going to get a reading here. So it's going to be that PR segment. But when we calculate it, we're going to calculate it as a PR interval. So we're going to calculate that P wave in it. So technically, if we're counting in the PR interval, we are calculating atrial depolarization with our AV depolarization all together. If we calculate the PR segment, that's just AV node depolarization itself. A normal PR interval is going to be between 0.12 seconds and 0.20 seconds, or 120 milliseconds or 200 milliseconds. Okay, so we measure it in terms of the PRI, how long it takes from that for that SA node to go all the way down and depolarize that AV node. Septal depolarization, that's going to be the Q wave, that first, which is a Q wave is defined as the first negative deflection following the P wave. Okay, first negative deflection following the P wave is a Q wave, and it's represented of that septal depolarization. So you go down, you get down that left bundle first, out that interventricular septal fascicle, and you move in this direction, right? So we're moving away from that positive lead positively, and we get that little negative impulse. But remember, we're now in the Purkinje system, fast, fast, fast gap junctions, fast, negative, and it's a small area of the heart. So small, fast, negative. Then we're going to get major ventricular depolarization. We come down, we're going down this way, right? And we add all of these together. We add all of these together, big, fast, and it's a positive moving towards a positive, big positive deflection, big R wave. The R wave is defined as the first positive deflection following the P wave. Major ventricular depolarization. Then we finish off with that basilar depolarization, smaller area of the heart, and we're moving up in this general direction, adding those vectors together, right? So we're going to be moving in this direction, but we're positive, but we're on the Purkinje system, fast, positive, away from a positive lead. So we're negative deflection on that, and we create that S wave, okay? All right. And this creates the entire QRS complex. And we actually measure this because we want to know how long it takes to depolarize the entire ventricle. So we're actually going to measure our QRS complex to see how long it is from the beginning of the Q wave to the end of the S wave. Okay, and we want it to be less than 0.12 seconds or 120 milliseconds. If it's greater than that, there is some sort of delay, and it could be problematic. So we have to look into seeing if it's a delay because it's stopping at the AV node. Is it a delay? Is it a delay because there's a bundle branch block? Is it a delay because it's a ventricular rhythm? So we want to know why there's a delay there. Okay, so you have a pause before repolarization of the ventricle. This is going to be your ST segment. Remember, we've depolarized the ventricles, and at the same time while we're depolarizing the ventricles, the atria has repolarized. The atria is ready for a new impulse. The atria are repolarized while the ventricles depolarized. Ventricles are depolarized and represented by that QRS complex. So then we have our ST segment. The ventricles are depolarized, and they're sitting in that just depolarized and hopefully contracted state. That's going to start at your J point. J point is the end of the QRS and the beginning of that ST segment. This again is important when we're talking about ST elevation or ST depression, because the J point is your point of reference to determine if something is, quote, elevated or depressed. And remember, we talked about how we don't want to use this PR segment to as a reference point to if something is elevated or depressed, because there's electrical depolarization happening through the AV node. We want to use this right here. So what I want to know is if this came up like this and was like this, I compare it to this line right here and I know that, okay, that's actually elevated. Or if this came down like this and I use this line right here, and I look for the J point right here, ooh, that's depressed. Okay, and we'll teach you that when we get into 12 leads as well. But use this T to P segment to measure that ST elevation and depression. Then, now that we've depolarized everything, we have to repolarize. Remember, we're gonna depolarize all the way down and we're gonna repolarize that last cell because it's squeezed and we can't move anything. And those outside cells are the ones that repolarize first. It's gonna do it at that very, very slow to moderate speed. And we're gonna become more negative. That negative, if we're talking about lead 2, is gonna move away from that positive, which is going to create a positive deflection, which is going to be our T wave or ventricular repolarization. Now, QTC or QT interval is the total duration of ventricular depolarization and repolarization. So we want to know how long it took for that heart to depolarize and repolarize, because if it takes too long, we're at risk for going into some lethal rhythms, because we can actually receive an impulse when we shouldn't be receiving impulses at this time. So we do not want this QR interval to be delayed. So we can measure the this QT, sorry, we want the QT interval. We don't want that to be delayed. So we want to measure this QT interval. So the QT interval is going to be, again, the depolarization to repolarization, and we can measure it on the EKG machine, or there's what's called the corrected QTC. So what this means is it corrects the number or the range that is normal based on two things: the rate of contraction or speed of conduction, the rate of conduction, so the amount of complexes, your heart rate basically, and your sex. So each heart rate and each sex has a different QTC. Okay, and we want to calculate that either with a mathematical calculation, or you can look at the top of your EKG machine and it'll actually calculate it for you to see if it's actually fitting within that range. So men have a QTC of between 0.35 seconds and 0.45 seconds, 335 milliseconds or 450 milliseconds, and women have a corrected QT of 0.3 seconds or 0.4 seconds, or 360 milliseconds to 470 milliseconds. Anything greater than 500 is concerning for a prolonged QT, and we have to be very cautious about any drugs that we give that could prolong that QT, which is a lot of drugs that even we carry. So we have to keep that in mind. Okay, and then and if it becomes over more than 600, we really need to be cautious and not give anything that's going to be creating a prolonged QT with any of the drugs that we could potentially be giving. So what this is this is just showing those action potentials as it moves throughout the heart. We talked about this, these nodal cells, how they have that sodium into the calcium with kicking that potassium out. And we have the same thing here with our SA and AV node. And then we have these contractile cells that actually have more of that plateau type phase that's based on that sodium, potassium, calcium, and potassium, and then kicking that potassium back out to get back to that resting membrane potential. And it just kind of shows how it goes, how it's going to do that throughout the entire conduction through the heart. So we have slow conducting, everything else is moderate speed conducting, and then this His-Purkinje system is our fast gap junctions. Very, 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 very quick through there. Something to know as we start to treat our patients is we have an absolute and a relative refractory period in terms of these action potentials. So the absolute refractory period, which you see right here, okay, that absolute refractory period, the heart cannot accept a stimulus. So the heart, as it starts to go through this depolarization, it can't receive another impulse. And for obvious reasons that you're probably thinking, well, why would it want to do that? Well, we don't want it to. We don't want it to receive another impulse because we haven't even finished with this impulse, right? So we don't want to receive an impulse. Well, it absolutely cannot through this phase. But during our relative refractory period right here, it can receive a it can receive an impulse there. And if you remember from what we've learned so far, is this is actually your T wave. So this is going to be R on T phenomenon. This is where you can actually create an impulse by a lethal rhythm by an impulse hitting at this relative refractory period when it's not quite ready to receive an impulse, but can, and you get your R on T phenomenon where it can go into a ventricular lethal rhythm, which can be very bad. Now, you may know of this as like the commotio cordis and thinking about like the baseball player that got hit in the chest or that chest trauma that causes this. But remember, there are lots of factors that can actually cause this here. But the one we think about very commonly is those types of patients. And that's what's happening is they get that big hit right at this exact time. And that's what causes that R on T phenomenon. And then they go into a lethal rhythm. Let's look at the complexes again and go through those segments, intervals, waves again. So we have our atrial depolarization. It's a moderate speed, slow and small area of the heart. Okay, we measure the PR interval, so the atrial depolarization and AV node depolarization. Well, we want that PR segment to be a nice pause so that we can have that blood filling those ventricles so that we can hopefully get a appropriate amount of blood to our body. Okay. And we know that if we have something like a P wave that goes directly into a QRS complex, that can be problematic. It could mean that our heart isn't filling up with blood. And there's actually some conditions that could be the case. So that's why it's really important to look for all these things and make sure all these things are present. Okay. We have our QRS duration. We want our ventricular depolarization or hopefully ventricular contraction to be less than 0.2 seconds or 120 milliseconds. Any delay there could mean that we're not in that His-Purkinje system. Remember, that the voltage is this y-axis, but time is this x-axis, right? So if my QRS complex falls under 0.12 seconds, we know it's moving quickly. But let's say it spreads out and it's nice and wide. That's not good. Something's delayed there. And if it shouldn't do that if it's traveling on that His-Purkinje system, right? That's supposed to be the fast conducting cells with all those gap junctions. What's going on? Well, there might be a block, or it might not even be on the His-Purkinje system at all. It could be ventricular, right? So that's why we calculate this and we pay attention to this. The J point, we talked about how we use that where the S wave ends and the ST segment begins. So the QRS ends, ST segment begins, and we use the T to P here to as our reference point for if this J point moves up or if this J point moves down to measure ST elevation or depression. Okay, we talked about the QT interval. We don't want depolarization to repolarization to be too long. We talked on how that can make your R on T phenomenon easier to happen, and it can cause that impulse to be able to come in prematurely and can cause lots of problems, specifically torsades, right? The torsades that comes in, that we can see that twisting of the points of that EKG, lethal rhythm, very, very bad. Okay, when we have the R to R distance, that's actually going to be hopefully represented by our pulse. So if we have a contraction here and a contraction here, we can actually measure the R to R interval to measure our heart rate, which is pretty cool. Okay, so let's talk about the steps to rhythm interpretation. When we're looking at a rhythm, Okay, we need an organized format. We have to go step by step by step, because if you're not going step by step, you're gonna miss something. You're gonna miss something super important. We have to start from the beginning and work all the way through. Okay, so the first thing we want to look at is regularity. Think of this, kind of silly to think about it, but think about it in terms of like a metronome. So if your metronome is going off, it's just going to go click, 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 click. That's regular, right? Now, if I have something that's irregular, it's going to click, 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 click. That's irregular. That's not right. So that's what we're thinking about in terms of our heart. We don't want our heart to have an irregular rhythm to it. So that's what we're looking for, and we can see that on those QRS complexes. Okay, we're looking for rate. What's the rate of conduction? Because the rate of conduction is going to be representing our heart rate. And we want to look for P waves. We want to make sure that the P waves are upright and they're representing that we have come from the SA node, right? If we're coming from the SA node, we know it's going to be moving in that direction towards lead 2, that positive lead, and it should be an upright P wave. If I have a P wave that is upside down, it means that that impulse is moving in this direction, which means I'm probably not coming from the SA node, right? It can be problematic. So that's what we're looking at with our P waves. We talked about the PR interval. That's going to be at our AV node. We don't want it to stay there too short or too long. If it starts staying at that PR interval for too long, it could just drop that beat and we could have an AV block. So that's what we're looking for with the PR interval. And then the QRS complex, how, so we're talking about how quickly and efficiently our depolarization of our ventricles are. We want it to be less than 0.12 or 120 milliseconds, because if it's greater than that, there's a delay. We're on the fast conducting system, but there's a delay. So we have either a block or we're not on the fast conducting system. So we have to determine that. And we'll go over that when we get to the 12 leads. So regularity, is it regular? Is it irregular? And are there any patterns to that irregularity? So it may be bump, 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 bump. That has a regularity to it. Did you kind of hear what was going on there? That's actually a regular, irregular rhythm. So a regularly irregular rhythm, meaning that there's actually some type of regularity to it. Now, if you have something that's just all over the place, and this is going to be represented by like AFib, where it's just boop, boop, click, 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 that's going to be your AFib. That's your irregularly irregular, okay? And then those irregularities could actually be ectopic beats. What an ectopic beat is, it's a beat coming from an abnormal area of the heart, somewhere it shouldn't be coming from. So you have your premature atrial contractions, you have your premature junctional contractions, and you have your premature ventricular contractions. Those are your ectopic beats, and we'll go over those more later on, but they're going to be the abnormal beats coming from an abnormal outside of the normal conduction system, and they're typically happening early. Okay, so they happen early, and they typically aren't perfusing, which is what can create that irregularity, right? So it can be click, click, PVC, click, click, PVC, click, click, PVC, which is why it's actually staying pretty regular, but then creating that little irregularity in there, okay? So something to keep in mind when you have an ectopic beat is to actually try to feel if it's perfusing. Do they actually have a pulse with it? So this is going to be your regular versus your irregular. So that R to R interval is going to be different, for those. Okay. Rate. What's the exact rate? And is the atrial rate the same as the ventricular rate? Ways to calculate that. So a normal is 60 to 100 if it's coming from that SA node, right? And bradycardia means it's less than 60 beats a minute. Tachycardia is greater than 100 beats per minute. And we'll show you how to calculate these. One way to do it is by the R wave or the QRS complexes. You're actually going to measure from box to box. So you want to find one of these QRS complexes that falls right on one of those big boxes. That's the best way to actually calculate it. And it's calculated by taking 300 and dividing it by the R to R interval in the large squares. So you can see that there's one box here. So if you take 300 divided by 1 is going to be 300 beats a minute. If you take, there's two boxes in between here, you take 300 divided by 2, this is going to be at a rate of 150. 300 divided by 3 boxes is going to be 100 beats. 300 divided by 4 boxes is 75. The other way you start to get really good at this is calculating it just by doing this. You can say I have 300, you're going to say I have 300, 150, 100, 75, 60. And you start memorizing those numbers and you can calculate it that way. So you can either do 300 divided by the boxes, or you can say 300, 150, 100, 75, 60 as you just kind of hop over the boxes. This is a 6-second strip. You can know that based on these notches. If you print this out, if you do a simple print of the EKG machine, typically it's going to be lead 2 that you print, but this is actually representative of 3 seconds. So remember, this is time, okay? So the x-axis is time. So this is going to be 3 seconds in between here, 3 seconds here. So if you wanted to, and you could calculate it this way. Now you have to calculate an irregular rhythm this way. And the reason is because if you think about, let's think about doing the box method here. I found this one is pretty close to that big box. And if I do 300, 150, 100, so it's a little more than 100, maybe like 120. Oh, but if I do it here, let's see, if I do it here, 300, 150, 100, that one's pretty close. But if I was to do this one, do you see how this would actually be closer and I would get a different rate? And because of this irregularity, I actually just need to do it on a 6-second strip or a 10-second strip if I'm doing a 12 lead. 12 leads or 10-second strips. This is representative of that 6-second strip based on these little notches that are here. So what I'll do is I'll count my complexes: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay. I think we got different numbers here. So, oh, it's because that's outside that 6-second strip. So they're right. So they're right. They can count better than me. So we have 11 times 10, which is going to equal 110 beats per minute. Well, we know because that's greater than 100, this is going to be tachycardia. But this is irregularly irregular. And we don't see discernible P waves. And because of this irregularity, and that there's lots of these fibrillatory waves, this is actually going to be AFib. Remember, we talked about the P waves. Are the P waves regular? Is there a P wave for every QRS complex? Why do we care about that? Well, we want to know that the SA node, hopefully, if it's an upright P wave like this, right? Okay, so we want to know if the SA node generated the impulse. Well, if there's a P wave associated with the QRS complex, it means that that impulse came from the atria down the AV node and stimulated that ventricular complex. So what it's saying is that's a good thing. That's the right way for it to be. So we want to know if there's a P wave associated with QRS complexes. P waves that don't generate a QRS complex or aren't associated with the QRS complexes means that there's some kind of block or problem or dissociation, and we need to be aware of that. So what it means is the P wave in front of the QRS or behind it, meaning before the QRS complex or after the QRS complex. That again can be problematic. So we talked about if it's normal and upright in lead 2, right? If there's a positive here and a negative here and it's upright, it's probably coming from that SA node. If it's negative, we might be concerned that it's not coming from there and it's going backwards. So that might be a junctional rhythm or the AV junction. So traveling backwards from the AV junction away from that positive lead and creating that negative deflection. So that's what it means by why we ask if it's upright. Are there more P waves than QRS complexes? Again, we said P waves not associated with QRS complexes could mean there's some sort of dissociation or block. Do all the P waves look alike? We want all of the complexes, all the wave segments, intervals to look the same. If they don't look the same, there's some kind of variation in what's happening, and variation is bad in terms of how our electrical conduction is looking. We want it to look the same every time. And are the irregular P waves associated with ectopic beats? So are there irregular P waves, and are they associated with ectopic beats? Determining if there is some kind of PAC, PVC, or PJC. So the PR interval, are the PRIs constant? Is that PR interval constant? If the PRI starts to vary, it means there's a varying degree of delay at the AV node and is problematic. We want it to be the same every time. And is that PRI measurement within normal range? And if it varies, is there a pattern changing to the measurements? You'll learn that when we start to go over the AV blocks. QRS complexes are all the QRS complexes of equal duration, meaning less than 0.12 seconds or 120 milliseconds. What is the measurements of the QRS complexes? And is the QRS measurement within normal limits? Do all the QRS complexes look alike? Remember, we don't want to have variation in our morphology. Morphology means what it looks like. If I have one QRS complex that looks like this, I want the next one to look just like that, right? I want it to all look the same. If something's different, it means it's something has varied or is different, and that's not good. Are the unusual QRS complexes associated with ectopic beats? Are there ectopic beats there? PVCs, PACs, or PJCs? So we talked about how if the QRS is wide, that it could mean that it's either a block on that Purkinje system, like a bundle branch block, or it could be ventricular in nature, not even on that Purkinje system, or through the bundle branches and the Purkinje fibers, not on that fast conducting system. So we want to determine the width of that QRS, and we measure that by, like we said, the beginning of the QR to the S. So if I calculate these little boxes, I know they're 0.04 seconds, okay? So I want it to be less than 3 little boxes, 0.12 seconds, okay? So this one is less than 0.12 seconds or 120 milliseconds. Well, if I calculate this one out, this is a slurred S wave, and so it's actually coming up and ending here. So that's more than those 3 little boxes. So this one's going to be wide, okay? So we talked about how if we have a wide rhythm, it could be a block or outside the Purkinje system and coming ventricularly. So supraventricular means above the ventricles. We know that this is narrow, which means it had to come through that AV node down the Purkinje system quickly. It's supraventricular. Ventricular means it didn't pass through that AV node and it's coming from the ventricles, from the bottom. And because it didn't go through that Purkinje system fast conducting, it's going to be wide and delayed. So we just to reiterate, the narrow QRS complex, a narrow QRS complex means a supraventricular focus above the ventricles, so coming through that AV node down that fast conducting system. And then a wide, broad QRS can mean a ventricular pacemaker or a supraventricular pacemaker that was delayed with a ventricular conduction system. We talked about the blocks or the bundle branch blocks, other things like that. So we'll talk about those more when we get to the 12 lead EKGs. All right, I appreciate everybody's time today. This was really fun. I enjoyed talking about cardiology, and I think this was a good intro to what you'll get later on in the courses. And I look forward to seeing you again.